All right, I think we'll get started. We may have some other people coming in, but thank you guys so much for being here today. My name is Mark Auerbach. I am the co-chair of the section of Emergency Medicine Pediatric Readiness Subcommittee, and both Teresa Walls and myself are very excited to start what we believe will be a long journey with the Pediatric Emergency Medicine section working together with the section on hospital medicine, critical care medicine, and many others to address some of these challenges and opportunities that we'll hear about today. So I'm going to pass it over to our esteemed speakers, and I will be helping to manage the chat box. This will be recorded. You are all muted. If you can include questions in the chat box, that would be greatly appreciated. And thank you so much. And I'll let the speakers introduce themselves and we'll get going here. Thank you.
Hi, good afternoon, colleagues, and good morning to some of you. We are very excited to talk to you today about ensuring optimal pediatric care to the acutely deteriorating child in community hospitals. As we navigate this virtual webinar, we look forward to your participation and questions. Feel free to post your questions in the comments and we'll aim to answer them at the end. We have no financial disclosures. So the overarching goal of this presentation is to describe the current state of the management of the acutely deteriorating child in our community hospitals, the challenges to their optimal care, as well as to start the discussion on what could be needed to support our community hospitals in the management of the acutely deteriorating child. We have a total of 4 presenters in today's webinar who come from a background of pediatric critical care medicine as well as pediatric hospital medicine. And I will let each of them give a brief introduction.
I am Corey McDaniel. I am a pediatric hospitalist at Seattle Children's and Providence Regional Medical Center, which is a community hospital.
I'm Pesha Koski. I'm a pediatric hospitalist at Rochester General Hospital in Rochester, New York, as well as Gonzaga Children's Hospital.
Hi, Scott Krugman. I am a pediatric hospitalist and outpatient doc and vice chair of pediatrics at the Herman and Walter Samuelson Children's Hospital at Sinai in Baltimore, Maryland.
Thanks, everyone. So before we start our respective sections, we wanted to hopefully visually demonstrate a roadmap for today's webinar. The goal is that each presenter's sections, although separate, will fulfill a bigger categorical thought process of a gap at the beginning and the gap of the acutely deteriorating child management in community hospitals. And then in the middle, we will talk about examples and experiences with some challenges and barriers. And at the end, talking about potential next steps. So Dr. McDaniel and myself will be talking about the current gap in the care of the acutely deteriorating child. And then Dr. Pakowski and Dr. Krugman are going to talk about community examples of how this gap has created challenges and variability in the care of the acutely deteriorating child. And then Dr. McDaniel and myself will come back to start the discussion at the end of how we can move forward to supporting our community hospitals in the management of the acutely deteriorating child. And so with that, we hope at the end of this webinar, you will be able to describe the hospital structure and care for children in the community hospitals. Define what is an acutely deteriorating child. Report system-level challenges to caring for the acutely deteriorating child in the community setting, as well as describing the variability in their care, explain the impact of how different care delivery models on the acutely deteriorating child, and then hopefully get involved in a collaborative approach to support our community hospital care for these acutely deteriorating children. And so with that, Dr. McDaniel will get us started on describing the current situation of community hospital practice when it comes to children.
Okay. All right, thanks all. I'm going to start us off by talking about the epidemiology of care for the acutely deteriorating child in community hospitals. So when we think about just the general epidemiology of pediatric hospitalizations, we know that somewhere between 5,000 and 6,000 children in this country are hospitalized each year. In data, the most recent data we have from 2012, we see that children are hospitalized in just over 3,700 general hospitals and 50 freestanding children's hospitals. for a total of around 4,000 hospitals in the US that admit pediatrics. What we can see from that is that 93% of hospitals that admit children within the US are admitting children to non-freestanding children's hospitals. So when we look at what that means for the actual pediatric hospitalizations, if we take that initial 5 million peds hospitalizations a year, around 72% of those go to general hospitals, meaning that around 28% of all the admissions a year are to freestanding children's hospitals. But of that 72%, that breaks down into around 17% get admitted to children's hospitals within general hospitals, and 55% get admitted to community hospitals. So let's pause for a second, because I just threw out a whole bunch of terms. And the terms, when we start to talk about the landscape of taking care of children within this country, becomes very confusing, because there's a lot of terms, and these terms are not necessarily mutually exclusive. And within any given term, it can represent a very disparate picture of what services are available and what level of care is available within any given term. In addition, we tend to throw out monikers that we think mean one thing and often can apply to multiple different institutions. So let's break this down a little. So if we start with the 4,000 hospitals that admit pediatric patients in the US, the first kind of natural divide is where we started on in my first slide. So you have freestanding children's hospitals and general hospitals. And freestanding children's hospitals are the ones you most commonly think of. So Seattle Children's, where I'm at, or Nationwide Children's, like where Dana is at. And these are hospitals that have your full complement of not only pediatric subspecialties, but provide referral and tertiary and quaternary care for children. And then you have general hospitals, and general hospitals is just a large kind of catch-all term that means it's an adult-focused institution. They take care of adults, and they may or may not take care of children. Within general hospitals, then, that differentiates into children's hospitals nested within a general hospital. So an adult-focused institution that also provides a specified area known as a children's hospital, and then community hospitals. And it may be a little bit surprising the kind of hospitals that fall within this like nested children's hospital, or a children's hospital within a general hospital. And that includes places like Johns Hopkins, which again has the full complement of referral subspecialists. They do liver transplants, all of the things, which is clearly a very different bucket than your community hospitals. However, even within your community hospitals, there is a lot of variation. So you have some hospitals within the community, maybe they're larger, that are still adult-focused institutions, but may or may not have some subspecialty capacity, some subset, which Natalia will get into, even have ICU capacity, all the way down to your very rural, small access hospitals like Forks Community Hospital, which you can see represented up here, which is a critical access hospital here in the state of Washington. Now, of these hospitals, which ones are academic? Well, the truth is, any of these hospitals may be considered academic, as academic is defined as an engagement in evidence-based practice, scholarly work, and quality improvement. So any of the hospitals, down from your smallest, most rural hospitals, all the way through your freestanding children's hospitals, may or may not be practicing actual academic practices. And similarly, you'll hear the term teaching institutions thrown out. And within pediatrics, most community hospitals all teach trainees, whether that's medical students, nursing students, NP students, et cetera. 90% of community sites that employ pediatric hospitalists consider themselves to be teaching institutions, as they instruct trainees on a regular basis. In addition, more than 50% of MS3s in this country complete at least one rotation during their third year at, quote, non-teaching institutions. So for the purpose of this talk, we're going to define community hospitals as kind of these bottom two definitions, either a pediatric unit with designated beds and space within a general hospital, but without the extensive pediatric specific ancillary staff and subspecialists that a children's hospital would have, or a pediatric beds within a general hospital, which are just licensed beds that may or may not have a pediatric specific unit. So if we take all of that and look at then the epidemiology of pediatric hospitalizations, what we see is that most kids for medical, mental health, and surgical diagnoses are admitted to general hospitals. Your general hospitals are in the black bars, and you can see that for essentially every single one of these categories, that more kids are admitted to general hospitals than they are to freestanding children's hospitals. However, when you break that down by cases per hospital, because there are so many general hospitals, the number of cases that they see in any given condition is much smaller than in a freestanding children's hospital. For example, when you look at pneumonia, while there overall are thousands of admissions for pneumonia a year, the average number of pneumonia cases per general hospital is much smaller than the average number of cases of pneumonia for a freestanding children's hospital. So this data gets even more granular when we start to look at that in the scope of rural healthcare in this country. And what we're seeing on this map is the distribution of children less than 18 in rural communities, with your darker blue being more children and your lighter blue being less children, and your white areas being they're not rural areas. So there's about 12 million children in the US who live in areas considered to be rural. When we look at just critical access hospitals, which is a Medicare designation in order to receive certain financial reimbursements from the federal government, as well as to help support, maintain services within rural communities, what we see that of those 12 million, about 1.6 million children receive pediatric acute care services within rural hospitals. However, of the 1,300 critical access hospitals in this country, 80% see less than 5 children a day. So when we start to think about how this frames for pediatric healthcare delivery in community hospitals, it becomes this balancing act of, on one side, we have more than 12 million children, and we have more than 3 million admissions that's happening every year within community hospitals. But on the other side, on the individual hospital level, we see low pediatric volumes, which leads to limited experience a lot of times. We have limited pediatric resources because you don't have that full complement of not only specialists, but also things like lab, techs, equipment, medications. And within community hospitals, they're adult-driven institutions where resources are really allocated towards reimbursement on the adult Medicare-focused side. And so from the global viewpoint down to the individual hospital, that starts to affect pediatric care in a lot of different ways. So kids are cared for in community hospitals outside of the emergency department in many areas that you would recognize, things like newborn nursery, mother-baby unit, inpatient unit, if there is one, and a NICU and PICU, if there are one, but also in other places within the hospital, the PACU, the adult ICU, if you're a 15, 16, 17-year-old, sometimes you may get admitted to the adult side, or the adult medical or surgical unit. Mom gets admitted, she has a 2-week-old baby, there's nowhere else for that baby to go. And so the baby's sitting in the hospital room with mom, which leads to a lot of different people taking care of children throughout the hospital, which begs the question then, when you have a child who is admitted to the hospital outside of the emergency department, what happens when that child begins to acutely deteriorate and become critically ill?
Thank you, Corey. So that brings us to the acutely deteriorating child. What is an acutely deteriorating child? We think that a potential definition could be any hospitalized pediatric patient who experiences a change in their PU score to 5 or greater. At that moment that a child acutely deteriorates, they need to have their care providers recognize and respond to stabilize that patient. Once that occurs, a decision needs to be made. Do we manage this patient in the current setting, or do we transfer them to a higher level of care? Each of these steps has its own challenges. For example, the fact that a child admitted to a community hospital deteriorates is very rare. And so this comes with less experience as well as a lot of anxiety that has to do with it. In addition, as we will see with our next presenter, there's a lot of variability in protocols of who to notify and who to respond to these rare events. Being able to recognize and respond requires multiple resources spanning various levels. And this continues if the patient is deemed appropriate to manage in the current setting, or if the patient needs to be transferred to a higher level of care. With each of these branches comes challenges and barriers, some which have been described in the literature. So in the next couple of slides, I'd love to touch briefly on the challenges and barriers that have been described in 2 studies coming out of Canada. I'll do this briefly before we press forward with Natalia's portion of the webinar. So in this first study from McMaster University in Canada, 5 community hospitals were assessed for their needs around caring for a critically ill child. The barriers that were identified included staffing issues, availability of specialized staff, lack of up-to-date pediatric acute care knowledge. The care required for one critically ill child rendered the ED staff incapable of meeting other patient care needs. Again, in a similar study from the Ottawa Hospital, a community hospital was assessed for its gaps in management of acutely deteriorating patients, and similar needs were identified, like lack of access to human resources, lack of a standardized way in identifying deteriorating children. This same group included this visual concept map to try to propose some solutions to the needs. So if you look at the middle column, those are the needs identified, and the flanking left and right columns are proposed solutions. Those span different or systemic levels, like organizational solutions of staffing, as well as some educational and clinical solutions. These same system level needs also exist within our own community, within our own backyards. And examples of this are going to be described by our next presenters. And so with that, let's turn it over to Natalia to talk to us about the resources and the pediatric hospitalist role in our community hospitals when responding to the acutely deteriorating child.
Hello. Sorry for that. Okay. So I will be talking about what's actually happening in community hospitals, what's happening for all of us who are right there in the trenches. So as you all know, in a general hospital, a pediatric hospitalist can wear very many hats. Depending on what the situation called for, many of us act as attendings, consultants, subspecialists, sedation providers, or even anesthesiologists, neonatologists, emergency physicians, or critical care physicians. So several years ago, we did an informal survey asking community pediatric hospitalists questions about what happens when there needed to be a response to a critically ill child in their workplace. And the next several slides just show some highlights from this survey. So first, we wanted to ask, well, what kind of resources you have for pediatric services in your hospital? And the responses are all from the 80 people who responded to the surveys, 80 hospitals. So as you can see, there's a huge variability in everything. Only 60% of hospitalists said that at their place, there is a 24/7 pediatric hospitalist in-house. There is about a quarter of hospitals who said they had a pediatric ICU, as you can see here. However, less than 5% have 24/7 intensivist in-house. So again, you know, intensivist is not in-house. Somebody has to respond to the children who actually admitted to the PICU. There is a large percent that has a neonatal ICU, over 70%. There's about 25% who have a pediatric emergency department, and about 30% have 24/7 residents in-house, whether they're family medicine residents or pediatric residents. However, almost 20% responders said that they actually do not have either pediatric or neonatal provider who is in-house 24/7. The other question we asked, well, what's happening with the Pediatric Code Team? And again, Pediatric Code Team, it's, you know, I'm not sure there's a survey out there, but I can't picture a children's hospital, whether it's a nested or freestanding, without a Pediatric Code Team. So what happened with our responses is that about 50% of responders said, yes, we have actually a separate Pediatric Code Team. About 20% said that there's one team for all ages. And over 20% said there's only adult code team. They do not have a pediatric code team. And the small percent was actually unsure what they have for the code team response for the pediatric patients. We asked about PAL certification, you know, what's happening to those who respond to this pediatric critical care event. And we asked for physicians and non-physicians responders. You can see for the physician responders, 50% showed that, yes, all physician responders are PAL certified. But 50% said that, well, only hospitalists and residents are certified, but we actually don't think that other ones are. Non-physician responses were even less sure. There's less than 30% non-physician responses, and that will be nurses, respiratory therapists, or even mid-level providers, that less than 30% have PAL certification, almost similar amount don't, and actually a whole large percentage, largest number of people responded that they don't know, which means that if a pediatric hospitalist, you're at the bedside in this code situation, you actually may not know who on your team has PAL certification. All right, so then we kind of tried to figure out, well, this is what's happening with services and response, but what is the role of the hospitalist? So we asked, who does your hospital staff usually call to the bedside for an urgent provider evaluation of a hospitalized pediatric patient? So 65% of people said, well, everybody calls the hospitalist, and we actually have the process for it, and it's regardless of which primary service this child is on. But 83% said, well, we don't really have a specific process, but we get called anyway. So 83% of the time, it's the hospitalist who gets called in these institutions. And finally, the question is, well, where do you respond? And we wanted to ask it because it really matters whether you respond in the ICU, where you may have very trained nurses and a lot of equipment available, or whether you respond somewhere else where it may be not as high on resources. As you can see that the hospitalists respond all over the place. So pediatric unit is the obvious one, but as hospitalists, we respond to adult ICU, pediatric ICU, radiology, emergency department, PACU and perioperative units, neonatal response, delivery room, as well as outpatient area. As one of the hospitalist responders put it, if there is a child in trouble within the walls of the hospital, we will take the page. And I know many of us on this call kind of feel this way. So now we called in, we're at the bedside for this child, and let's say it's past PALS, right? Because we have a pulse, the child is, has some respiratory support. The question is, what is going on through my mind? What's happening to this child? And for all of us in these situations, there are many questions that go through our minds. Transfer, not to transfer. Well, if we're transferring, should we request transport or should we call the advanced life support ambulance? And we all know it matters, right? Because transport will take a while to get in, ambulance we can get right away. And how long do we need to take care of this child before this transport is available? A lot of variables in that. How far is your receiving hospital? What's availability of transport team? What's the bed availability in your receiving hospital? And how stable the child is for transfer. So last season for all of us was pretty bad respiratory season. And we had days and weeks when our receiving PICU was full. And we had over 24-hour wait to take care of the children who had respiratory support before we could transfer them. So other questions as we stand at this bedside is like, well, what resources do I have and what resources do I need, right? So physician resources, somebody has to be at the bedside immediately and for the length of the time we need to take care of this child. And again, for all of us, it will be different. Some of us have hospitalists in-house. For other, for example, in our institution, in our hospital, we respond to these events from home overnight, but our residents are in-house. So it's a very different person at the bedside. We all usually need some help from the PICU specialist. Again, for some of us, it's a PICU specialist in-house, but for most of us, it's either phone or telemedicine or some other way we have them on the speed dial. Pediatric specialists, whether it's a surgical critical care or maybe cardiology, many of us don't have this in-house, which means phone, telemedicine, some way to figure this out. Other resources, acute care for the nurses, how experienced are the nurses near us? Do they have procedural skills? Will they be able to get, for example, capillary blood gas on the child? Or what are the pediatric competencies of these nurses? For example, we have adult ICU nurses responding to pediatric code. They're great, they just don't have pediatric competencies. Respiratory therapists, the same question. What they experience, procedural skills and pediatric competencies. And of course, pharmacists, experience, pediatric competencies. Are they on site? Can they program this pump for us that we require to put the prostaglandin or milrinone or whatever else we're putting into it? And who is going to help us with it? And do we have the medication? Now, these were all human resources, so to speak, but there are many other ones. Equipment, respiratory. Do we have the right size prong for this child for the high flow? Access, do we have the right size central line? I'm not even saying who's going to be putting the central line or this PIC. What's the medication delivery? Is there pump? Is there medication available on our formulary? And of course, what is the best location for critical care? If we have to wait for 6 hours for transport, where this child should wait. And all of us will be answering this question differently because it really based on the what's the best room setup, staffing, equipment available, or is there telemedicine? For example, for us, it's our emergency room. We have a pediatric emergency room, and that is the best staffed place for pediatric critical care. So we will try to transfer this child from our pediatric unit to the pediatric ED. So, and of course, the other resources, other processes, to do all of this care and manage this child, and the processes that are evidence-based, that can work locally, that apply to all diagnosis and scenarios. These are rare events, and we still have to be able to respond to them. The processes that hopefully minimize human error and they're sustainable over time. So we all try to answer these questions and be prepared. And what do we try? So I think all of us try to do some preemptive actions in anticipation. For example, pediatric rapid response. We instituted it in our hospital several years ago based on Pew's, and the one-year analysis showed that over 50% of our pediatric ROT events resulted in change in management of the patient. And this is great value for us. Other people may approach their situations differently. And all of us try to do some admission triage. When we get this call from the ED about the admission, well, should I try to admit and kind of take care of this child here, or should I just say, no, I'm not admitting, and please transfer the child? Of course, that brings the question, well, we're going to transfer the child, but can you please come down and help us with the management of this child while we're waiting for this transfer? We all try to identify our internal resources, whether it's anesthesia, or adult ICU, or emergency. We try to build external bridges with local ambulances, with our receiving hospitals, subspecialists, and ICU providers. And we try to do gap analysis, but let's face it, gap analysis is often post-event. So something happened, we're reviewing this rapid response of this code, and well, we didn't have this medication available in Omnicell on the floor. Let's talk about it. So we try to kind of analyze it and fix it retrospectively. And of course, we try to do a lot of mocks. Whatever can be mocked, we'll do it. Whether it's a rapid response mock or code mock or any other mock, we're happy to try it. And the question is, what is so unique to us in community hospitals, to our pediatric hospital medicine? Many of us know the saying that, as I learned, is attributed to Jack Purcell. If you've seen one community hospital, you've seen one community hospital, and that's because we're so different and we have such different resources. But are we truly that different and unique? Does it actually mean that we have a lot of similarities? And I would argue that we do. That we may have very different resources, but we have very similar needs. And that will allow us to kind of focus on the functional need assessment, where we need to be in the end to be able to provide this care. Because that part can be standardized. It also will allow us to draw from existing expertise and evidence from pediatric emergency as well as pediatric critical care medicine. And it also will give us different options to achieve the end results, because we will have different internal and regional resources that we can utilize to develop our own processes and competencies. Of course, collaboration and benchmarking is very important, and to try to make sure that we can maintain and develop our quality and safety standards, as well as the value of having this national standards. And I think this value is great, because if there are national standards out there that this is what you need, this is what helps, and this is what you should be able to do, not only will allow us to develop this pathways and implement these resources, but it also will give us leverage to go to our own institutions and say, hey, this was published in pediatrics. You really don't have a choice. Let's please send our respiratory therapists to get them this training, or get our So the bottom line is that who needs a superhero when you're a hospitalist in the community hospital settings?
Okay, I am going to take over. Hopefully, yep, it did work. So we're going to take into a little broader picture. Natalia did a great job looking at sort of what to do on the individual basis with some degree of comparison. But I think there are multiple threats that are facing community hospitals out in the world right now, externally, internally. And we need to be prepared to deal with them, because the biggest issue is if you don't even have a pediatric hospitalist, you're not going to be able to respond to acute illness at all. So the current reality in the situation that we're living in is that more kids are getting transferred to children's hospital and tertiary care centers across the country. There's been multiple studies. If you want the data, I can provide it for you, but there are fewer capable pediatric emergency departments in the community now. So we have not made a lot of progress in the community setting to respond to critically ill children's needs. And the challenge ends up being, how do you provide high quality care with limited resources, because no one has a full slate of pediatric subspecialists in their community setting, with highly trained staff that can maintain their training despite the fact that they might have very low volumes, in a child-friendly environment. And that's really a big challenge to do. So we need to think about this from a system standpoint, and how do we create systems to respond to and improve the care of critically ill children. So we're going to go through each of these little bullets in a little more detail with the current challenges and solutions. But rule number one is you got to have somebody in the hospital, right? Number two is that person has to be present when the child arrives, whether they're in the ER, whether they are in a in the inpatient unit, whether they're in radiology, wherever they might be, they have to be able to respond. But more often than not, at least in the community setting, the most critically ill kids often roll into the emergency room. You need support staff who are competent to care for children. That's nurses, RTs, people who draw blood, the whole gamut, which Natalia mentioned. Appropriate supplies, and we'll refer to and talked about the pediatric ER readiness checklists and toolkit that are out there. And then there has to be accountability and leadership. So is this service even valued in the hospital? So step one, you need to keep your hospitalist program. And this is easier said than done, because there are a lot of threats and there are a lot of challenges to being a pediatric community hospitalist program out there. One is, overall, our rates of pediatric admissions are going down, and this has been accelerated due to COVID, interestingly enough. Number two, we just don't get paid very much for what we do. Dudas et al. In pediatric emergency care averaged about $300 per case. That's over a whole hospitalization. That's not a lot of money. That's not going to keep you afloat just doing inpatient care. Most community hospitalist hospital medicine programs, and even non-community hospitalist medicine programs in children's hospitals, are being subsidized to exist. Dan Rauch and I scoured the literature and got some help from some friends, and the best we could come up with, most recent data is 2016 from the SHM productivity survey, and each hospital on average subsidizes programs almost 152,000 per FTE, and many of these programs have 5 FTEs, so it does happen. That there's a lot of money that goes in. There's clearly fluctuations in census daily, seasonally, and there's no longer anybody else out there doing inpatient care. So community practices aren't coming into hospitals anymore. They're even abandoning newborn care in a lot of places as well. So it's being relied upon by the hospitalist program. So how do you survive? How do you survive in this type of environment? Well, one, the best bet is to do as much as you can so you can make as much money and therefore stay alive, and people don't question that. You can maximize revenue by doing billing, trying different procedures. Some people run circumcision clinics, all sorts of different things. My personal favorite, and the one we're going to talk a little more about, is decreasing geography, so you can more effectively care for more patients in a safe setting. You can expand services. As Natalia mentioned, some people are doing sedation services. Others have done things like urgent care and outpatient as well. And then there's the option of partnering with the children's hospital. So really outsourcing the care to a children's hospital and relying on them. And that's become a bit more common as well over the past decade. The next step is to be accessible. And I'm going to focus on being accessible to the ER, but the same holds if there's an inpatient who's very sick, and where do you take care of them? As Natalia said, sometimes they go to the ER when they start deteriorating. So geography does matter. And one of the biggest challenges for hospitalist programs is that you can't just care for inpatients. You have to cover multiple areas. And most programs cover to some extent inpatient, emergency room, and nursery. And the percent of each one varies by program. So as you've seen one hospitalist program, you've seen one. So some have most inpatient, some consult in the ED, some have most nursery, some inpatient. It just completely varies. So how do you do this? And I think that the opportunities that you can to co-locate services and combine staff will make your life a lot easier. So is there a way, are there hospital renovations where you can put 2 or 3 of those services in the same place so you don't have to go so far? If you are trying to get to a delivery on the first floor while covering an inpatient on the second floor, and then the ERs in the basement on the other side of the hospital while a kid's coding, you can't be in all 3 places at the same time. But if your inpatient unit and your emergency pediatric ER in the same facility, it's a lot easier to go across a hall. Other places have done combined nursery inpatient units. Others most commonly combine adult and pediatric units, and whether the same people care for them usually doesn't happen, but has in the time of COVID with the popcorn network. We have medical surgical units and inpatient urgent care. There's a lot of different things that you might be able to combine, which could increase, 1, your revenue, and 2, make it easier for you to respond to critically ill children. So just to highlight briefly the combined pediatric ER inpatient unit that has been pretty popular in the Maryland and Mid-Atlantic region. The goal is to consolidate the majority of the pediatric care of the hospital in one location. And this maximizes staffing efficiency. There's less fluctuation in volume with ER patients. You have cross-functional staff who can care for sick kids in the ER and in the inpatient unit. And you can maintain competencies because everyone keeps busy, at least seeing kids every single day. Data from Dudas and our group at my previous institution, MedStar Franklin Square, showed that this unit improves quality, improves patient satisfaction, even though ED noises can be loud, improves throughput time, and improves financials for the hospitalist program. So transitioning to support staff, as mentioned, this is a big challenge in community hospitals because it's hard to find pediatric specialized people. And most people who are in pediatric or in community hospitals have to do adults and kids if you're an RT. You can't just do pediatrics. And if it is a low volume hospital, that you can't maintain your skills. And when you don't use certain medications or supplies very often, they might expire or not be available when you need it post. So again, if you have geography in one spot where you are doing sicker kids all the time, that helps maintain skills and supplies. As Natalia mentioned, mock codes are a great way of keeping up skills and making sure you have the supplies when you need them. Another option is to think about partnering with children's hospitals for staff training, job sharing. Make sure you have people, not just doctors who are seeing kids all the time, but the nurses and the support staff. And then we'll talk more about the pediatric emergency checklist, but this has been published. It's worth looking at and walking down to the emergency room and going through the list and making sure someone's in charge of keeping up with it. And that gets to leadership and accountability and who's making sure things are happening in the community hospital. The biggest issue is that pediatrics is not the focus of the hospital. These hospitals are primarily focused on adult medicine, oncology, orthopedics, things that make money. Emergency medicine groups really might not be so enthusiastic about partnering with pediatricians. They might be independent contractors that get money from seeing patients and don't want the pediatricians to be taking any revenue away from them. And senior hospital leadership really might not understand the complexities of pediatric care, the intricacies, and how it relates to other services. So you can find yourself in a situation where you're always swimming upstream trying to get the resources you need. So I think some key things are relationships. Clearly make sure you have friends in senior management who understand what's going on, that you're partnering with the ER and they're on the same page with regard to pediatric care. And even if they own it, they are meeting those requirements that are needed to provide high quality care. Partner with other departments like surgery, ENT, who rely on inpatient pediatric beds at times, have some key board members in your pocket, and make sure your hospital has a mission to actually care for the community. That does help as well. There are a lot of threats coming down the pike, in addition to the basic, we're just a community hospital that doesn't care about kids. Hospitals are now getting squeezed for bundle payments, for which can trickle down to reduced payments for inpatient services and hospital service, because the whole thing comes as one bundle. COVID-19 has been a huge impact on community hospitals, with volume drops, redeployment, caring for adults, adding adults to the unit. All sorts of things have happened across our country. Hospital consolidation, where regional places are gobbling up community hospitals, I think is going to keep going. And we've seen a lot of closure of pediatric units and beds, especially in rural areas, but also in suburban areas as well. And I think that trend of needing to travel is not going to go away anytime soon. So a few take-home message and lessons learned from my experience is, one, the more flexible and the more cross-training you have, you're more likely to be sustainable and to keep things going. If there is volume, you want to find it and go get it. If you can get a geography that helps you consolidate care and do two things at once, your life is going to be a lot easier. And I think the care will be a lot better of the sickest child. Don't get complacent and prepare for the worst, because even if you do all the right things and make a lot of money, your hospital can still shut you down. And that's what happened to me a couple of years ago, and it's not so fun. So good luck out there, and stay alive and stay working in the community, because we need you.
Okay, so where do we go from here? So Natalia and Scott have really set up that there are many challenges to caring for the critically ill child in a community hospital on multiple systemic levels, and not just from the provider standpoint of physicians, nurses, other staff, but also from the equipment, supplies, and leadership levels. So how do we, as community hospital providers, as emergency medicine specialists, as university-based pediatric hospitalists, as critical care physicians, all come together to partner with our community hospitals in order to support the care of the acutely deteriorating child? So let's take a brief foray into the world of pediatric emergency medicine to see how we have addressed this in the ED. So the ED, similar to the inpatient world, sees a lot of kids. So they see more than 80,000 children a day within the emergency department in the US. But 70% of those are seen in community EDs that see less than 15 pediatric patients a day. So very similar in some ways to the landscape and scope of the pediatric world. And the 2006 Institute of Medicine report revealed that although children make up 25% of all emergency department visits, most general EDs do not require specialized pediatric training for clinical staff, and did not have the full scope of pediatric equipment, meds, or supplies necessary to take care of emergent or urgent cares of a critically ill child within the emergency department. And from that, the National Pediatric Readiness Project was born. And the purpose of the National Pediatric Readiness Project was really to establish a baseline for the nation's capacity to provide care for children, to create a foundation for emergency departments to engage in ongoing quality improvement for the care of children within the ED, and then to establish benchmark measures for improvement over time. And this was done through a multi-stakeholder engagement process between the AAP, the ENA, which is the Emergency Nurses Association, and ASAP, the American College for Emergency Physicians, all with the aim to ensure that emergency departments have essential guidelines and resources to provide effective and appropriate pediatric care, which led to the development of the Pediatric Readiness Toolkit. So the Pediatric Readiness Toolkit is an evidence-based policies and procedures, checklists, and additional resources to help EDs to support achieving essentially the readiness for an urgent or emergently ill child. This includes things like interfacility transfers and a checklist of kind of the 6 essential pediatric domains, and then additional considerations for disaster preparedness. And in order to figure out where on the spectrum of pediatric readiness are you, there's developed a 55-question online survey that provides a weighted score so that you know kind of what are the things you most need to focus on. And although we talk a lot about the need for physician and staff training, train, it turns out that that's only a very small percentage of kind of all of the other factors that go into the ability to provide acute care for a critically ill child. And so, there we go. The Pediatric Readiness Project was launched in 2016, initially with 14 states joining the QI Collaborative and 11 additional states joining after. And then round 2 in 2018 was a second collaborative that really targeted low volume EDs. And what they found was a measurable reduction in morbidity and mortality for children requiring urgent and emergent healthcare within the emergency department. And we all know within pediatrics how challenging it is to actually show reductions in mortality. And so there are a lot of potentially really great learnings that we maybe can extract when thinking about how do we take the learnings from pediatric readiness in the ED and extend that to pediatric readiness for a critically ill child, regardless of where they are within a community hospital.
Thank you, Corey. And so this takes us to our final section of today's webinar. We believe it will be important to make a national statement similar to previously published guidelines and recommendations that focus on the acutely deteriorating child in community hospitals. This will require a systematic approach that ensures that each of the 6 domains are evaluated, continuously improved, and supported. And so the overarching goal would be for our community hospitals to assess their gaps in those 6 domains and to form targeted solutions that are sustainable. For this to happen, we believe that it's going to be important to define what a community hospital exactly needs to be prepared to manage the acutely deteriorating child, to develop a standardized checklist of basic must-haves, and to provide some support for system-level solutions. All of these things are going to need a very collaborative national needs assessment, as well as we're going to have to prioritize needs in terms of a weighted score, come up with processes, resources, and standard guidelines, and solutions that are sustainable. One of the most important parts is sustainability, easily accessible with methods for assessment and QI improvement. And so with that, we hope that this webinar can be a call to arms for those interested in expanding pediatric readiness to inpatient care. We would love for those who are interested to email us out on this email, inpatientpedready@gmail.com. And of course, we look forward to continuing and expanding on these concepts and hopefully a webinar coming in the spring. I think we do have a couple of minutes to answer some chat questions if we want to take a look at those. And we've also provided some emails and Twitter accounts for our speakers today if you want to individually email us out. But I'll leave these slides. The email is inpatientpedready@gmail.com, and here are our separate emails.
So thank you so much to our esteemed speakers. This is Mark Auerbach again. We really appreciate your time. So a couple of the questions and comments in the chat box, I'll just highlight some of those if you have not been following along. One question came up related to EMTALA, and I think that there was a clear response that as long as there's a higher level of care that you can transfer to an ED, and if those services are not available in your hospital, an inpatient to ED transfer is acceptable, that EMTALA really is to treat and stabilize to the best of your abilities, and that can be transferring to an ED setting. Another question that came up was related to the annual volumes for which a hybrid ED inpatient unit would be ideal versus impractical. We did have Bob Dudas respond that 8,000 to 10,000 visits per year with about 2 to 3 inpatient census. But Scott, perhaps you can comment on that as well.
Yeah, I think there's sort of a sweet spot in that at the low end, 8,000, probably 10 to 12 to 14 is like the ideal with 3 to 8 inpatients as your average daily census. But once you hit over 15,000 PEDS-ER visits, you might as well just have a PEDS-ER, and you probably have enough volume to support an inpatient unit. So I think from a community setting, having that you know, around 10,000 and around 500 to 700 admissions a year is a great way of putting the boat, you know, having both units, both places combined into one unit. Let me put it that way.
Thank you. Another question that came up was Jeff Gill asked, did the Readiness Project provide resources or guidance to fund the recommended changes? The readiness survey did actually identify the cost of training and the cost of resources as a barrier. So in the survey, people asked about barriers on the emergency department front. That there have been some cost effectiveness studies that have been done, but I would encourage you to consider working together with your regional EMSC, Emergency Medical Services for Children program, and or regional children's hospital. Those are groups that have at times done very creative and innovative interventions, even with supply chains, where there are some states where the community EDs stock equipment and the children's hospital sort of has it shipped to them as it reaches its expiration date. So I would certainly be happy to chat more with anyone about that. There was a question about whether or not from Margaret Satchel if the survey was available. I did put in the chat box the initial paper by Marianne Geshe-Hill. As someone involved in emergency medical services for children, I want to make sure to highlight that while the hospital work is very important, that we do actually have our national assessment coming up. It was supposed to happen this past summer, but it will be coming up in July of this upcoming year to assess all of the emergency departments. And that survey will go to the emergency department nursing director, and we have a pretty complex plan that hopefully will lead to a fairly high response rate, over 80–90% as we had in the past. But I did list that assessment link in the chat box. Another question that came up from Jeff Gill, which was, if I were designing a strategy to consolidate pediatric care at a children's hospital and close down community sites, I might come up with this as part of that approach. Discolored by politics, maybe. So I would say that yes, that there is sort of this friction between children's hospitals and community hospitals that we're hoping that friction can actually be smoothed out, and this can be all about supporting the best care for all children anywhere and everywhere. So the email addresses for contact are listed there. This webinar will be posted on the PEDS Readiness website that we have through the EIC or the EMSC Innovation and Improvement Center. Nikki Sims wrote, I am a community intensivist. Can you speak more about how we could help, or would you? Yes, I'd like to speak more about how community intensivists can help. I think that the piece that did not come up here, and the lens that I think future webinars should and will take, are integrating both neonatal as well as pediatric intensive care unit doctors into this work. So maybe Dana, you can comment on that a little bit here. I know this was sponsored by hospital medicine and emergency medicine. We have now engaged transport medicine and critical care medicine in this work stream, and hope to have them involved in the next webinar.
Thanks, Mark. I think that the biggest thing that intensivists in general could be helpful with is being able to list those system level needs to stabilizing an acutely deteriorating child. Most helpful from a community intensivist perspective is talking about what resources are available in your community hospital and what is manageable, what is within your scope versus something that is definitely outside of the scope of a community hospital's management of the acutely deteriorating child. What respiratory therapists, nurses, pharmacists are able to handle. So we would love to continue this discussion. I think it's going to require a lot of specific steps moving forward. And that's where gathering all of our like-minded individuals under this email listserv that we provided could continue further discussions on this topic.
And I would like to highlight, just with the context of the Pediatric Readiness Project on the emergency department front, that this has been a 30+ year journey. So I want to highlight that this is not sort of something that's going to be an overnight success. I think it's going to require a lot of collaboration and work together. I do think with the changing landscape of healthcare in the US, there are some critical crossroads, as Scott mentioned, that we're approaching with potentially closure of hospitals and potentially real disparities studies looking at rural versus urban settings. So I think this work is really critical. Bob had mentioned the potential of having a listserv. I think our goal was that we'll email out everyone who attended this webinar. You can also contact this email that's listed here. And our hope is that we can begin to have this group come together under the auspices of the AAP, potentially engaging other societies and groups to have the individuals on this call, as well as many of you, helping to lead some of these efforts. Are there other questions or comments before we sort of close out here? If they are, please lift them in the chat box. If they, as I'm asking for that, I just want to thank Dana, Natalia, Scott, and Corey, who put in a tremendous amount of work. This will be a publicly available webinar. We'll post it on the EIC website as well as a YouTube channel. And we look forward to future collaboration and engagement. And you know, Corey and Dana are at the beginnings of their career and are looking forward to conquering this over the next 20 years. And they and others will be leading this effort. So congratulations to the four of you and to everyone. Have a happy and safe holiday, and really appreciate the opportunity to share in this challenge, but an opportunity. So thank you so much. Have a great day and be safe and be well.
Thanks, everyone.
Thank you.
Mark,
Yeah,
can you hear me?
yeah.
I appreciated your last comment about the 30 years. This is Ken Roberts. I was with Jim Seidel in the APA maybe 20, 30 years ago, and got involved with these surveys of readiness back then. And as you talked about, actually Hill being an important person back then, we kept talking about how, what are we going to do about this? What are we going to do about this? And between ACEP and the APA and other groups, didn't go as far as we wanted, but it sounds like it's finally an idea whose time has come.
Yes, I think we've made a lot of progress on it in the past number of years. Thank you so much for joining. Appreciate it.
Oh yeah, we used to do scavenger hunts. You know, go down to the ED. Can anybody find a 3.5 tube? You know, that sort of stuff. And
yes, still doing that. All right, thank you so much.
This is very good. Thank you.
Thank you.